Anterior cruciate ligament revision using quadriceps tendon autograft and lateral extra-articular tenodesis. The authors declare no conflict of interest. This video demonstrates our surgical technique for a one-stage revision of ACL reconstruction using a quadriceps tendon autograft with a patellar bone plug combined with lateral extra-articular tenodesis. This case presented with ACL graft failure associated with tibial tunnel widening. Preoperative CT scan shows a non-anatomic femoral tunnel being anterior to the femoral footprint. The tibial tunnel's position is too posterior, and therefore there is a high risk of tunnel convergence while creating the new tunnel. Preoperative clinical examination shows a positive anterior drawer test and a pivot shift test. The knee is flexed to 90 degrees to place tension on the quadriceps tendon. A 3 cm median longitudinal skin incision is made starting distally from the superior border of the patella. The skin is retracted superiorly to visualize the quadriceps tendon. Proximally, the graft is harvested through a percutaneous skin incision. The patellar bone block, measuring 2 cm in length and matching the width of the tendon graft, is outlined, and subsequently, with an oscillating saw and an osteotome, a partial thickness trapezoidal-shaped bone plug is harvested. The total length of the graft measures approximately 80 mm. The proximal end of the graft is prepared using a fiber loop suture with a fiber tag implant. Distally, the bony plug is prepared by drilling 2 perpendicular holes of 1.5 mm. A vicryl suture loop is passed through the distal hole and the 0.8 K wire is passed through the proximal hole. Initial arthroscopic inspection shows a tear of the medial meniscus treated with an all-inside suture. No lesions were observed in the lateral compartment. The tibial ACL remnant is debrided and the tibial guide is used to drill a K-wire from the anteromedial tibia towards the anatomical footprint. Straight reamers of increasing diameter are passed over the K-wire starting with 4.5 mm and progressing up to 10 mm. The tibial tunnel is then inspected to make sure it is at least 3/4 debrided from the previous graft. The femoral socket is created in an inside-out fashion by using the flip cutter. The femoral socket is then visualized to make sure the walls are debrided and intact. A metallic suture shuttle is introduced into the femoral socket and retrieved from the tibial side. The graft is then pulled through the femoral socket until the button is completely seated against the lateral femoral cortex. The adjustable loop is then shortened until 25 mm of the graft is inserted into the femoral socket and the bony plug is seated in the tibial tunnel. Tibial fixation is obtained by inserting a metal screw. Double tibial fixation to a monocortical screw is optional at this step. To perform the lateral extra-articular tenodesis, a lateral incision is made starting from Gerdy's tubercle up to 2 cm proximal to the insertion of the lateral collateral ligament. The posterior border of the iliotibial band is identified, and distally a 10 mm IT graft is lifted off Gerdy's tubercle with a sleeve of periosteum and sutured with a 0 vicryl suture, which is used as a shuttle. The lateral collateral ligament is then identified. The graft is then passed underneath the lateral collateral ligament, and then a double-loaded suture anchor is inserted a few millimeters distal to Gerdy's tubercle, to which the graft is sutured with the knee at 30 degrees of flexion and the foot in neutral rotation. The repair is reinforced anteriorly and posteriorly with vicryl mattress stitches. The iliotibial band strip is then sutured to the LCL using one non-absorbable stitch. The fasciolata is then sutured. Cancellous bone from the initial harvest is used to fill the patellar defect, and then the quadriceps tendon is sutured. And here are the postoperative x-rays.